Hey, Rachel.
Yeah.
Hi. So Val got caught up in a procedure.
Okay.
So I guess I will be introducing the case using her
Okay.
using her slides. She just sent
Okay.
it to me.
That sounds good. I'm gonna move something in my background because I have like a weird blanket there. Hold on 1 second.
Oh, we can't see the weird blanket. Looks the artwork
Bye,
was
buddy.
nice though.
It's in my car. All right, I'll see you tomorrow, Mary.
See you tomorrow.
It was good seeing you. I'll see you next week, Flo. I'll see you at Renal Week.
Yep.
All right.
We're all going to Renal Week.
Hey, Mary and Abity.
Yes.
Okay, so I created a new poll EV for this just for some quiz questions, keep engagement. I just have to activate them. I mean, I have a PowerPoint.
Oh, yeah. Do you want to try give it a shot?
Yeah, let me try. Why is my PowerPoint not open? Oh, because let's see, share that. And then if I go to, well, hold on, I have to be in presentation mode, don't I?
Yeah, it's going to be in presentation mode. And then you should be able to.
I have it active on the app.
Let me see if I can, let's see. So I need to pull EV.com. Rachel.
You can just tell people to join that when they start.
Yeah, because it'll take a minute to enter it in. Unless there's a text option, that's usually a little faster, but this is fine too. Why is it asking me I don't need to log on? Why is it telling me I need to log on? Oh, I don't think it actually
not. Maybe we'll just.
It didn't do your stuff. Why is it not? I must probably just click something that I shouldn't have. Go. It's not giving me the option of not signing in.
Oh.
Is there, can you make it that's really annoying. Can you make it a text option too? Although that would be done for all of them, I think. Or maybe it's just me having the problem. Yeah, if you scroll down, you should be able to from the web and then turn text messaging on, and then that should give you the option. Yeah, and then you can text. Okay.
I have to do this for the other ones then. I didn't see that. I remember to do that whole thing, make it anonymous that we did last time.
I don't even know how to tell who did what, even if you forget to do that.
This one doesn't let you, I guess, because you'd have to do it on the. This one's a click, so maybe it doesn't let me do that.
It could be that you didn't have it active, and maybe that's why it's telling me to log in.
Oh, I thought I activated that one. Oh, that one does.
Yeah. Try it again.
It does say the text now.
Okay, so 22333.
And then you have to click it. This might be more trouble than it's worth. I'm glad we at least tested it out and see.
No, so the text is pretty easy. Then you just have to enter in
your answer.
Your Rachel Cianciolo 543 to that number, and then it comes up. Either way, you have to still go somewhere.
Okay.
Yep, and now I can join. I'm joined, and
then will you be? Do you have to do that each time I have a question, or do you have to just do it once?
Once you're logged in for the whole session, it works. And then if you, but it's not pulling this one up, try going out and bringing it back up again because it's not showing me your question.
Oh, I think I just did the answer probably. I think the way I did it was. This one is the one that does have everything for this. as the question, and then I can do the responses. I think when I saved the other one, I just said save the answers.
Yeah, it's still not popping up, so I wonder if it's not active. That may be the problem with both the web and. So,
That one is probably not active. Sorry for anybody who is just joining. I'm not sure how many people we have here. We can just stop at some point. Okay, that one didn't have the.
to see live content.
Okay, we'll figure that out later. We were trying to have a polling situation with questions. The questions will remain, they just won't be fancy represented on the screen. So we used a polling app when Dr. Nabedy and I were speaking in Australia. We have occasionally used it when we were using Teams. However, we recently switched to Zoom because Dr. Foster is persnickety about Teams, and Dr. Foster suggested that we move our meeting application to Zoom because the American College of Veterinary Nephrology and Neurology already has their own Zoom account. And when we record this way, everything is being recorded as we speak. When we record this way, it's very easy to transfer it over to our channel for archiving these sessions. Therefore, this makes a little bit more streamlined workflow. If you, as we're getting started and as people are still joining, the housekeeping notes that we do every month include the fact that we always are looking for volunteers for case presentations. Doctors Foster and Skinner have been superstars when it comes to volunteering. Tufts is in a close, well, maybe a middle second place for volunteering. They've done a few cases. So that's always been helpful to have people of different experiences and different backgrounds present the cases. There is never a requirement for anything fancy. This is not supposed to put the resident extra burden workload for them to create a gorgeous PowerPoint. So this is not anything about extra workload. It's just an opportunity for them to present the case or the attending clinician to present the case and give the clinical background. And then we pause for the biopsy results, and then we often discuss treatment. We usually can get through one case. If it's extensive, it might take about 30 to 40 minutes. And we can always kind of try to squeeze in a gee whiz at the end. So if you ever have a case that you want presented, or you just want us to discuss it and you're not really sure what's going on, and you don't want to be put on the spot, please feel free to request those as well. So if you send biopsies and you're like, hey, I have no idea what's going on, I don't know how to treat this animal, especially if it's still a recent biopsy, please ask us, and we are happy to make that the topic of conversation. If we don't have cases requested the week before, then we cancel rounds. So I just want to make sure that this doesn't become pathology talking nonstop, because I probably would talk nonstop about kidneys, and I don't want that to be the format. So I really want engagement from the clinical side as well. Looks like we've got a good group of people here. And we are transcribing the notes. We are recording the notes. We do have a couple pop quiz questions. However, the app is not working to submit your answers. So we might just ask you guys to volunteer or raise your hand when it comes to the question part. Next week is Renal Week, just an advertisement for that. Most of you guys are aware that it's happening. Some of you guys will be in attendance. I will be there talking about kidney biopsies. So I think I have a lab on Thursday and Friday. So I hope to see you. If you're there in person, please feel free to reach out and say hi. There probably maybe are still options for virtual attendance. I think that it actually kind of got booked with Sidekick Dr. Hocamp. I think it got booked for physical space, but because it's so popular. But there's probably still opportunities for virtual attendance. So if you guys need us to do it, we can put the link in the chat. Does anybody have the link maybe Mary or Hocamp can put the link in the chat in case you guys want to sign up for the
I'll work
virtual
on
meeting.
that. I'll
Okay.
work on that.
And then next set of rounds will be in April. Please keep the opportunity for watching for invitations. In my last housekeeping, which I say every month, is that sometimes Outlook decides to kick people off the distribution list. We have no rhyme or reason of why that happens. If you have noticed you have not gotten any contacts from me about rounds over the course of a month or two, feel free to reach out and say, hey, did I accidentally get kicked off the list? We will re-add you to the distribution list. There really is no reason why people get kicked off. Dr. Hocamp has been kicked off the list before, and it's Dr. Hocamp, so we have no idea why it happens. But if you noticed that you have not gotten any email communication about me or from me about rounds, just text me or message me, and we'll make sure you're back on the list. Today's case is from Tufts University, the clinician is working up the case. She's kind of involved in another procedure, so Dr. Lobato is stepping in for her very nicely and kindly to discuss the clinical aspects of the CAT for today.
All right, if
You should be able to share if you have anything.
somebody else is sharing. The
Oh,
host
I
isn't allowed.
Stop share. I'll stop share. Does that
Okay,
help?
I see. Looks like it. Let me get to presentation mode. All right, let me minimize my screen here so I can see things.
Looks good to me.
All right. And so, yes, Val, I hate to say it, I believe she's doing an endoscopy of all things. There we go. All right, so Ginger is a 3-year-old spayed female Abyssinian who was referred to us at the end of January from another facility for management of an azotemic PLN. She had presented about a week earlier to her local veterinarian with a decreased appetite and lethargy that was noted on the 18th of January. There was a potential history of Peruvian lily exposure and at least an NSAID tablet or two lying around the house. And at presentation to an emergency room, she had creatinine of 1.5 and BUN of 20 milligrams per deciliter. Actually, I should say, and her physical exam findings, they thought she was maybe 7 to 8% dehydrated with a moderate skin tint. She was noted to have an intermittent gallop, 1 out of 6 in the left peristernal area. With femoral pulses that were strong and synchronous. She was considered to have some diffuse muscle wasting with a body condition score of 3 out of 9 and a muscle condition score of mild wasting. Her BP at the time was 140. Entering blood work
Have
at
you
the
advanced
local.
a slide? Because it's still on the slide with her photo.
Oh, really?
Yeah, I'm wondering if sometimes
Oh,
it doesn't advance the
it's
slide.
interesting. You know what? It's on mine. It's the next slide, but I have the blue circling ring of death here for a moment.
Oh, great.
Can you see that now?
No, all we see is Ginger's picture in the signalment.
Oh, that's weird. All right. Yeah, why is screen sharing paused on my side? I'm going to stop for a second and try to share it again. Why is that coming up?
I would think after, it's so funny. I get so frustrated with this as well, with how long I've taught on Zoom, and it's still
I want this one.
frustrating for me. I think when I was trying to create the quiz questions within Zoom, as we're killing time for this, apparently I don't even have it. Like, I know I have a Texas A&M Zoom account, but it won't even let me log in. Like, it's just, I mean, we use it
Okay.
every day, but
Do
okay.
you
Yeah,
see
now
her?
we see a
You see her?
table at, yeah. Mhm.
Yeah, okay, you've got that. All righty. So at the ER, her BUN creatinine were reasonable at 1.5 mg per deciliter, 20 milligrams per deciliter of her BUN. Her potassium was 5.2, albumin was okay, a low end of normal for their range at 2.9. She had a specific gravity on her urinalysis of 1045 and a 2.2 urine, a UPC. She then continued to be off at home, so they brought her back in, and her at that time her BUN and creatinine had jumped to 4.8 and 108, potassium 5.6, so creeping up a little bit. Her albumin had dropped to 1.6, and then her specific gravity was 1030. On a UA, they saw 3+ protein, but did not submit a UPC. They kind of kept her in the hospital. This was another facility, and she continued to have a progressive azotemia. So a day later, 24 hours later, she had bumped up to 7, creat 113 mg per deciliter on her BUN, and her albumin with fluid therapy had appropriately decreased, and her UPC at that time was noted to be 12. So this was also at the referring practice. Looked like she had, we have her urinalysis listed here with a specific gravity at 1027, 4+ proteinuria, 0 to 2 white cells per high power field, 15 to 20 red cells per high power field, a couple of epithelial cells per high powered field. They had started her on mirtazapine, telmisartan, clopidogrel, and Cerenia. So she presents to Tufts, and through the ER, they did a recheck, PCV total solids with which were 30 and 6.8, and ISTAT at the time showed a potassium that was elevated at 6.4. Her BUN was off the scale at greater than 140. They were able to measure a creatinine at 12.3. Her ionized calcium was 0.77. Her white count on a complete blood count was a little close to 17,000, and she had 691,000 platelets noted. The chemistry taken at the time of the ER admission correlated with a creatinine of 12, total calcium of 7.5, total protein of 6.2. Her albumin was 1.9. Her potassium had jumped to 7.2. Overnight, her vitals were mild heart rate of anywhere from 180 to 198. Her respiratory rate was in the 20 to low 20s to 30 range. She was a little hypothermic, so she was started on heat support, and then she had on abdominal palpation a static small bladder.
And actually, I'm gonna stop you right there. Can you
Okay,
go back to your slide? Can you go back to the previous slide? Because
sure.
I have a pop quiz question that I'm gonna try to show.
Okay.
Okay, so this is just to bring in the conversation of some of the terms that we use clinically, and actually I need to stop sharing for you, for these kinds of presentations. So I think you have to quit sharing.
Yep, trying to get my,
All
there
right,
you go.
just to and if we had the ability to run this as a poll, you guys could see everybody's answers come in. But so I think that for the pathologists in the call, there are a lot of clinical terms that nephrologists use. And so I just want to be sure that we're all okay about understanding the difference between these two. So for this particular cat, we have a cat that has a really high creatinine. We have a cat that has elevated UPC. And so there are a couple of different things that we probably could discuss for this cat. Can anybody on the call unmute and speak up what the difference between nephrotic and nephritic would be from a clinical aspect? So what's a nephrotic patient based on versus a nephritic patient? There's usually a difference that distinguishes the two. I'm gonna look at participants. Anybody interested in speaking? Clinicians?
Nephritic is when you have normal albumin, however, the patient is hypertensive and protein. One other thing that they might have. Yeah, but usually it's red.
Okay, so I heard that the fact that nephritic would be hypertensive, and what was the other characteristic usually? It was kind of faint hearing. It wasn't that I didn't, it was just kind of quiet, so.
Yes, we were saying that nephrotic syndrome is when patient losing albumin, has high cholesterol, high UPC, and nephritic syndrome means that patient usually has albumin within reference range. The patient is proteinuria and usually is hypertensive.
Okay, there's one other characteristic that I would consider for nephritic is usually azotemic. They're usually having some degree of decreased renal function. So not just proteinuric, but they're usually also azotemic. And then another characteristic is that when we look on the urinalysis, which is actually more important than the azotemia is kind of plus minus, but on the urinalysis, they usually, what we talk about an active urine sediment. So they might have, and you've rolled out UTI, you've rolled out any kind of lower urinary source for that, but you would have, casts coming from the kidneys. So in my mind, I think of nephrotic as being glomerulus pretty much only, and nephritic being kind of the whole kidney, to kind of keep those two separate. But you are very correct that nephrotic is based on loss of albumin through the kidney, through the glomerulus, proteinuria, hypercholesterolemia. They often are also third spacing, so they have edema or ascites somewhere. I apologize, my big dog just walked in the room and he's going to do a shake, shake, shake. So anyway, so nephrotic would be more just glomerulus and maybe not necessarily hitting the tubular epithelial cells, but a nephritic animal will have tubular epithelial damage in addition to proteinuria. Okay, if you do a nephritic versus an AKI comparison, they kind of will overlap, but an AKI animal doesn't have to be proteinuric. An AKI would just be azotemic, or even maybe not azotemic, but having a doubling of their serum creatinine. Maybe it's not out of reference range, but it doubled within 24 hours. Not necessarily having proteinuria. Once they have the proteinuria, then it kind of adds in the fact that the glomerulus has been damaged. So this cat isn't AKI only because we know that there's something else going on with the glomerulus. It did have a CKD background. So I think when Dr. Lobato was going through the information on the PowerPoint slide, it showed that everything was kind of a little bit normal in November. And I'm not sure, based on our history, when they thought the possible lily exposure or insect exposure could have been. But she'd had a baseline evidence of proteinuria in November with a fairly normal serum creatinine. So even in November, she would have been considered a CKD stage 1 because she had proteinuria. And then eventually, probably what happened with this cat is that then she had AKI event superimposed on her stage 1 CKD. So I would have answered this question that she's both an AKI superimposed on CKD and she has evidence of kind of a nephritic pattern. What do other clinicians agree with that? I'm going to stop sharing this.
Yeah, and I would add to that, Rachel, I think the time frame where they thought maybe exposure potential to Lilly and or NSAIDs was within the 2-week time period before her presentation.
Yeah, I think that's how I had read the history as well, was that we at least knew she was proteinuric because they had reference background blood work, which is, from the clinician standpoint, I think every clinician is very, very happy when they have a baseline blood work profile to go from. So when a patient comes in with a UPC, or sorry, with a creatinine of 3, and they don't really know what the baseline was, a month ago, it's hard for them to say, is this like CKD and we've just noticed it was CKD, or is it a true AKI event? And that's why having baseline blood work is so helpful for clinicians, and they are very happy when they have it. And so we know this cat had basically a level of proteinuria and then has a second hit, which is making it severely azotemic. Okay, cool.
All right, so back to where we're starting. So this is her initial presentation. She was transferred to medicine the following day with an oliguric AKI was the initial assessment, with severe progressive azotemia, hyperkalemia, and a component of a protein-losing nephropathy. There was marked hypoalbuminemia with some evidence of third spacing, and at the time, she was normotensive. Abdominal ultrasound was performed and basically showed there was a hypercoic cortices with some decreased corticomedullary distinction. There was scant piloactasia and evidence of some steatitis, they thought. There was a mild peritoneal effusion and some associated pancreatic edema. There looked like there was also mild gastric wall thickening, and they saw some mineralization in her left adrenal gland. So we have some images here showing the effusion, kind of a small collapsed bladder, and some mineralization in her adrenal gland, and one cute little image of her left kidney. What was elected to do was we decided to do a ultrasound guided aspirate of the cortex and also an ultrasound guided biopsy at the same time. And there was a small volume of self-limiting perirenal hemorrhage that was noted after the procedure, but everything went fairly well. These owners kind of wanted to see what was going on and if there was anything that was treatable. They were up for, if this had been a lymphoma case, they were game for therapy. If it was any other disease, kind of depending on what was going on, but they were hoping to, if we could, with an FNA, come up with a diagnosis, while at the same time we sent the biopsy sample down to Texas.
Okay, and I can start with the histology. And I think that's a good comment for, again, the clinicians, especially when we're talking about cats. Performing an aspirate at the same time that you're doing the biopsy, just to see if you can rule out the easy stuff, because lymphoma is fairly common in the cat kidney. It's kind of almost like when I think about a pattern of how you would do a bone marrow aspirate, but also take a bone marrow core, and maybe the aspirate gives you the answer and you can cancel the core part. That actually works fairly well with the kidney stuff, because usually your cytology is in-house anyway, or very quick answer with, any kind of digital cytology that's available. We often don't get the core until at Texas and until a couple of days later anyway. So if for some reason, even it's already sent off and it's already en route to Texas, you get the answer and it's lymphoma and you want to cancel the expensive test, that's always, just sending us an email to let us know that the sample that came through doesn't need to be evaluated. Sometimes you might want to just do histology just to look and see if we can, we can also with the histology do a few things for lymphoma that could be helpful as well to phenotype it for you. So we could do a few extra things if you realize while the sample's being sent off to Texas that you kind of already have a good working diagnosis with your cytology. So just keep that in mind about doing, planning for both, especially when we're talking about cat kidneys, not dog kidneys. Most people will just go ahead and process everything anyway. I'm going to check the chat to make sure everything's fine. Okay, we just have our information for, okay. Let's see so now we are going to try to show the histology, and of course I need to make sure my image is up. So we got the samples. We have been recently getting a few more canine samples, or sorry, feline samples than we usually get in the past. So it's been a few more samples. Some of them still are autopsy samples, so we get a little bit more information that way. But the feline samples have been increasing in number recently. And I need to go to so we get the histology first. Usually we get the H&E. They took 2 cores for us. I don't remember the number of glomeruli count, but we definitely have cortex when we're looking at these. I hope I'm sharing a renal core. Please correct me if I'm not.
Yeah, you are.
Okay. And it's the H&E, correct, Hocamp?
Yes.
Okay. It's a little pale today, whatever the stain was, a little pale, but we do have cortex. We've got glomeruli that are kind of popping out. They're a little prominent in the core. So the first thing that a pathologist does is look to see how much of the core has cortex, how much of it is medulla. I will say after going to many, I've been going, still continue to go to going to biopsy rounds at the medical school. You veterinarians get a lot better cortex than they get in the human biopsies. For some reason, the human biopsies just get tons of medulla, and I don't know why that is. Maybe they're just not as trained as you guys, but there will be plenty of times where we've had an entire round session for medical renal biopsies in the medical school, and we've maybe had 3 glomeruli for all the cases we looked at. We've had three glomeruli to look at. So I just want to give you guys congratulations on being better than the physicians recently.
I don't know if I noticed it. This was also a short excursion.
Oh, for the biopsy pass?
Yeah,
Okay.
yeah.
Okay, so we have some glomeruli in here. I did have a quiz question, but there's really no need to do it to launch it. But the glomeruli, even with an H&E, look abnormal. And so the kind of key features that I'm noticing on the glomerulus is there's a lot of material within the tuft. So normally a normal glomerulus is going to have gorgeous capillary loops at the periphery. It's going to have very limited mesangial zones. So this right here is mesangial zone, and it should have maybe 2 nuclei within a mesangial zone. And so this has a lot of material inside the glomerular tuft, and it's a consistent lesion. So it's in every glomerulus being expanded by material. So one of the things that is going through a lot of the pathologist minds as they look at this glomerulus, this is a great one, which is not only do we have extra matrix in here, extra material, I guess is probably the better word to say, but it's not yet small and collapsed. It's not a shrunken glomerulus. If we had seen a lot of material and it was a very small glomerulus, and then we would worry that it's completely scarred. And so can anybody unmute themselves and tell me what the word is when we talk about glomerular scarring? What's the pathology word for that? I'm going to start calling on people. Or I'm going to have Dr. Hocamp calling people so that they let you guys blame her and not me. Sclerosis.
Sclerosis.
Okay, good. Thank you. Good job. You guys are like, I'll just do it. Okay, so glomerulosclerosis. So that word just means glomerular scarring. If you talk about sclerotic collagen when you're talking about the skin, you're talking about scar. So this is the same thing. It's scar of the glomerulus. We don't say glomerular fibrosis. The reason we don't say fibrosis is this is not deposition of, sorry, and I want to say this is not glomerulosclerosis. This is something else, but I want to define the term of glomerulosclerosis. So it is scar of the glomerulus, and the reason we don't say it's fibrotic or glomerulofibrosis is that when the glomerulus scars, it just makes extra matrix that it normally should make. Glomerular fibrosis would imply that it's making fibrillar collagen, and the glomerulus doesn't make fibrillar collagen. So that's why we don't say the word glomerulofibrosis. Glomerulosclerosis means addition of the normal matrix it actually would routinely make. It's just way too much of it. And so that would be a differential for glomeruli that kind of look like they have too much matrix in them. However, I told you this was not glomerulosclerosis. And the reason I can tell you it's not is that if we look at this glomerulus, so I had the H&E and I had the PAS to start with. And so I think I messaged you that day to say what I thought it was. And so even though I didn't have the other stains, I had these two stains to look at. So if it were true glomerulosclerosis, which means collagen production by the glomerulus, the normal collagen that it normally would make, it should be all of this color. So see this dark pink? That's how glomerulosclerosis, the entire glomerulus should be that dark pink. And instead we have this paler material, this like lighter fusionophilic material on the PAS. And that's because it's a different material than the stuff that the glomerulus normally makes. Please put in the chat if you need me to reword that. Okay, so now compare that it's very easy to detect the difference on the PAS. The PAS shows, okay, we have GBM here and it's this dark pink. And then we have this extra matrix, this kind of paler pink material that's kind of expanding the mesangium. So that's really easy to pick up on the PAS. Now I'm going to go back to the H&E as a learning lesson. Where's H&E? Is this the H&E? Can't. I mean, if you can, then you're magic. But I can't see the distinction. Everything looks the same color on the H&E. So that's why the H&E is not very helpful for this particular case. Because everything looks pink or that same pale color, okay? And it's not even the fact that it was a light day in the lab and there was like a little bit less eosinophilic material or eosin in the stain, I should say, eosin in the stain. Like even if this were a gorgeously 100% perfect H&E, everything would be the same color. But on the PAS, it's clearly a different color. So I texted them immediately or messaged them immediately and said, I think there's probably going to be extra material that's not supposed to be here. In a cat, it's most likely amyloid. So that was our working diagnosis. And I said that we would do the other stains and that we would do a specific special stain that would be diagnostic for amyloid. And that is the Congo red stain. We don't always run the Congo red at Texas. And the reason behind that is we usually cut a big chunk for Congo red. You cut like a slide that's like almost 3 times as thick as your normal slide. And if we don't think it's amyloid, there's really no reason to waste all that extra tissue. And the reason you have to cut a thicker slide is that sometimes the amyloid deposits are quite small. And if you cut a very thick section, you're going to be more likely to pick up on those small deposits. So while we were waiting for this, the cat not accidentally, but sadly decompensated. Is that right, Dr. Lobato?
It's a good one. The condition progressed in the owner while we were waiting, and even though we said we think it's amyloid, but we don't quite know for sure, they wanted to try to continue to. So we said, okay, we'll. And the potassium was rising, and was over 7. We said, all right, we can do extracorporeal therapy and at least try to manage the potassium better for this cat until we get further results. And she was a trooper during catheter placement, not in arrhythmia to be seen. We then left her with anesthesia to go and finish setting up the carpe diem. and they extubated her because, and her temperature had come up to normal, and they turned around and she bradyed down immediately, and CPR was unsuccessful. So
So so we had sent a message in between, and I mean, in the end, I mean, it's very, very sad that this cat didn't make it. But as we're gonna see through the rest of the biopsy workup, it was a bad disease. So it really wasn't something we could have rescued. But we were able to get a little bit more information for this cat. So the reason this is kind of a little bit of a complex case is that we then got the next set of stains, and it's not just a run-of-the-mill, you know, we thought it was amyloid. It's not going to be a run-of-the-mill easy diagnosis, because there were some complications in our workup of this case. So the PAS definitely shows that color stain. The next two stains we often get for our biopsies are trichrome. And the trichrome will show everything that is kind of mesangium and GBM as a hazy blue material, depending on how much protein is kind of interwoven, because there's like a serum amyloid A protein. There are some carbohydrates that can get, not serum amyloid A, it's amyloid associated protein. It's AP, excuse me, I apologize. Serum amyloid A makes the amyloid. But there are proteins that can get interwoven with the amyloid fibrils, and there's some carbohydrates and some sugars that can kind of get embedded in there as well. So sometimes amyloid cases will have like a peach color. This one particularly is mostly blue, so which is within acceptable range. I wouldn't, if I had like bright red, I would think it's something different. But so the trichrome can be quite variable when we're looking at amyloid. It can be this blue, pale blue color. It's usually kind of this like kind of waxy blue, or like cornflower blue maybe is the right color to say it. And it can get all the way to a peach color. The Jones often does not really pick up and stain the amyloid fibrils. So Jones is really good for basement membrane material. So hopefully you guys can see I'm outlining a tubular basement membrane right there. So that's what the normal Jones color should be. It's going to outline Bowman's capsule basement membrane. It's dark black. The glomerular basement membrane is also dark black. But hopefully you can see there's kind of like this gray, pale gray material where the mesangium is. And that's kind of classic for what amyloid does. It basically has very small kind of like hazy amount of staining with the Jones. And so again, that kind of was consistent with the fact that we thought it was amyloid. Now I'm going to compare. I think we even had to repeat the Jones, which is part of the reason some of these glomeruli are different across the renal cores. But if you look at this one, hold on, let me go over here. So we've got some kind of hazy gray material. That's because part of the silver is kind of getting trapped there, but it's not a really good black labeling, which is what we would think for basement membrane material. Instead, it's this hazy gray. But if you go up here to our glomerulus here, this one is globally sclerotic. So you can see how it is completely black. It's because there's too much matrix that the glomerulus already made. It's just normal amounts of matrix that the glomerulus makes. But there's so much of it, and you can't really see the capillary lumens anymore. Kind of a shrunken the glomerulus is on its way out. If we had biopsied this cat, you know, I don't know, a year later, this would probably be just a small little nubbin of collagen. So sclerosis will be all black, whereas extra material in the mesangium, and it could be other fibrils as well. It doesn't have to just be amyloid. Any extra material in the mesangium will be this kind of pale gray scenario. Any questions on that? Okay, so what stain are you guys all waiting for? Somebody unmute and speak up, please.
Congo red.
Okay, cool. So Congo red. So we ran it, and this is the learning curve for Congo reds. So the lab had looked at it. They didn't really see an appreciable difference between the glomerular tuft and some of the background staining. So protein casts will stain kind of like the peachy color. That doesn't mean there's amyloid in here. It just means that there's proteinaceous material in here. Sorry, it's similar material that does stain peach. Vascular walls will kind of stain peach. So really nothing was jumping out about these glomeruli that was different than what was going on in the tubulointerstitium. And so the lab said, they texted me and they messaged and said, we don't think it's positive. And I was like, well, maybe it's very possible that there are other fibrillar diseases that happen in cats. And I was like, maybe it's one of these really uncommon fibrillar diseases that happens in cats. So we decided to go ahead and pursue the other diagnostic tests. And in the meantime, they sent me the slide. And so the learning curve of this is that sometimes when you're looking at a Congo red, you have to turn all the lights off in your living room or your house or wherever your microscope is. And let's see if I have the picture. And then you have to close your condenser on your microscope. You have to shield your eyes so that there's no other light coming in. I'm honestly not sure if I'm even, is my Zoom even showing all of my dramatic hand actions? It is. Okay,
Yeah,
guys.
it's just you. And also
Okay,
you can tell them it was like Hocamp wasn't sure if this was positive or not. Hocamp was like, I'm not seeing
it's
green
fine. We're all learning.
birefringence.
And
That was the birefringence, I think, right? That was
It was the birefringence. I can
birefringence
see-
was, so
yeah.
this is what we're talking about. So when you're looking for birefringence, the peach, really honestly, there will be sometimes where you can put the Congo red on and it's so peach and nothing else is staining. You're like, oh, this is definitely amyloid. There's nothing else it can be. So there's plenty of times where the Congo red really doesn't even require polarized light to call it positive. And what happens from a diagnostic workflow at the Texas Renal Biopsy Service is they scan the peach slide, but I can't look at the Congo red slide with my polarizer on a digital scan. Like I can't evaluate it that way. I need the actual glass slide. So if it's an equivocal case, then they have to send me the glass slide or they look at it themselves, which is what they normally do. And sometimes they'll be able to take photos with their scope and say, yep, I think it's positive. But this one was very difficult. However, we also then knew that the cat had been euthanized and they had the entire kidney for evaluation. So they, and I'm not sure, Dr. Lobato, they did a full autopsy, correct? They didn't just do a kidney removal?
They did a full autopsy.
And I'll show you a couple of the gross photos of the slices of the kidney, but I do want to show you, before I do that, I'm going to show you how annoyingly faint this material can be. So hopefully you guys are looking at a glomerulus and you can see this tiny bit of green material here and in here and down here and a little bit here. You guys, is it picking up? Can you guys see it?
Yeah.
Lights off.
Little-
Okay, it is not striking by any way, shape, or form. But the other thing is that remember that in real life, like I said, I've got like a completely dark room. I have my condenser, I have the light all the way up. I have the condenser all the way open to get as much light through that slide as possible. And the other thing that the pathologist is doing is going up and down on the z-axis. Yeah, the z-axis. So we're going up and down. And a little bit is popping up in each time because it is actually birefringent. It's not just glowy. It actually like comes in and out of focus, and you can see areas that show the green a little bit differently each time. Does that make sense to everybody? Do the clinicians understand that there's an art form to this? Hopefully. And so we still use this stain quite a lot, even though it can be tricky. And it can be a little difficult when the amount of amyloid that we caught in the section is not striking. So by the time the slide got to me, I proved it was amyloid. We also already had the electron microscopy to prove that it was amyloid, but it is a little bit of a learning moment for the clinicians for the pathologists that are on the call because you can miss it if it's this faint. Does anybody know, do any of the pathologists know what other structure will, hopefully I'm showing you my Lugol's iodine picture. This is not my Lugol's iodine picture. This is sent from Tufts when they did the autopsy. But does anybody know what other material, I'll go back to this picture, what other material shows kind of a polarizability with the Congo red, but it's not green? I'm going to ask that question again because I kind of rambled. So there's other material that will polarize when you have a Congo red stain, but it doesn't do the apple green color. Does anybody know what that is? Dr. Amerman, I saw you were on the call and you have an amyloid glomerulus on your picture.
I know, and now I'm gonna embarrass myself because I don't know.
Okay, so just normal collagen, like if you're looking at a normal vessel that has a good smooth muscle wall, that normal collagen will be white. Like it won't be green, but it'll refract. It'll have a refractile capability, so it'll be kind of like a white, like glowy, like material. Not glowy, that's not the right word. I mean, it is refractile.
Yeah, and Rachel, actually, I remember when I was doing this one, because I did it twice, because
Mhm.
I looked at it and I texted you, and then we went on another day, went and looked at it again. And I could see the white polarization of vessel walls, and I kept saying, no, that's not a glom, that's not it. And I kept looking directly in the gloms, and I was like, I feel like this should be there, and I'm not seeing it.
Yeah.
But
So
lessons
yeah, and I
in
think
self.
like again, like when we would look at these, and it's like burned in my memory. So we usually didn't have to go to polarized light for the human kidney biopsies that had amyloid. Oftentimes we already knew it because we knew it was light chain amyloid, and we had the IF to prove that there were light chain deposits in the kidney. So we rarely ever had to actually like prove amyloidosis based on the Congo red positivity. It was only when humans develop SA amyloid, serum amyloid A amyloid, as opposed to light chain amyloid. So when humans develop that, which is not common, it's very uncommon compared to light chain amyloidosis in humans, we would like, there'd be 4 or 5 human adults like packed into this tiny little room, all looking through a microscope and trading their eyes on the oculars to show that it was amyloid. So we would all sign off that, yep, there was green material in there. So it was not common we ever had to do that, but it was singed into my memory about being like crowded against like 2 of my attendings and then my other nephrology fellows trading off and arguing whether this was green or not. And it was really dumb because we were going to send it off for mass spec anyway. We were going to get the amyloid component anyway. So like we just were doing one extra step and it was very uncomfortable and you're like bouncing around. There's not a lot of room. And you're like in this dark closet. So anyway, so if my singed memory of being in a dark closet trying to look through a microscope reminds you at any point in time that that's why you do it that way. Hopefully that's your learning experience is hiding in the dark closet. So
We have a question on the chat.
Oh, yeah.
If you, about thioflavin.
Oh, okay. So we don't necessarily, we don't have to do that. They say that in the textbooks. I don't think I've actually ever run a thioflavin. Most of our amyloid cats that we've had through our service have not been this this difficult to interpret. They have been very striking amyloidosis. What we have showing, or I think the next, actually, no, I did want to show the next picture, was doing the Lugol's iodine. So Lugol's iodine is a material that you put on the slice of the kidney at the time of autopsy. And so it makes all of the glomeruli in this picture. I'm gonna have to, the picture, do you see all the little tiny black dit dots? Those are every single glomerulus. I did a little Wikipedia search today to figure out what Lugol's iodine history was about. It's an old drug used for hyperthyroidism. Of course, I ended the show. And also it can be used to treat iodine deficiency. They still occasionally use it because it's pretty good at binding to pre-neoplastic and dysplastic cells that are epithelial cells. So it can detect cervical cancer as a it's a good way. Let me say, like when they're doing a colposcopy and they're worried about cervical cancer, or they're worried about squamous cell in the esophagus, they will like infuse and like put down the Lugol's iodine at the time that they're getting ready to take the biopsy so that they can get the best place for the biopsy procedure. So it'll bind to neoplastic and dysplastic cells differently than the normal epithelium of those organs. And so then they can say, okay, this is where I want to harvest my biopsy from because it's most likely going to give me my answer, which is something I did not know. And I don't think we use in veterinary medicine. The whole thing is it actually binds to starches. So it doesn't really, it's not only for amyloid, it's binding to anything that has starch, but it's just that amyloid behaves as a starch, even though it's a protein. It behaves as a starch when it's abundant. So it will bind to the Lugol's iodine like as a bystander effect. But you have to have a lot of amyloid. You have to have like a significant amount of amyloid in the glomerulus or in the tubules in order to bind it up. And then previously, it was thought to be spermicidal. So it used to be used as a prevention from babies, just for FY pictures. But every single one of those little black dots in the in the renal cortex is a glomerulus. Sometimes when you have a case that has really bad medullary amyloidosis, you'll also see streaks in the medulla. This particular case did not have it. This is a gorgeous picture that they took at autopsy and sent to us to support the diagnosis of amyloidosis. Then I'm gonna quickly, because oh my gosh, I talked way too much. Dr. Lobato, is it okay if I quickly show the EM and then let you wrap up?
Oh, go ahead.
Sorry, guys. Did you have other stuff for the case though?
No, not really. I think that was it.
So they did a full autopsy. There were some other was there amyloid in the liver? I don't think there was.
I think there was, or that was very mild.
Okay.
Could you see her?
Hold on, let me get the EM stuff. Okay, so amyloid for the glomerulus is basically gonna look very similar in a lot of scenarios. So this, let's see if so the material, especially for the pathologists, especially for trainees that are learning about how to describe this, and not like I would say this would, I mean, this is probably like the one thing that's fair maybe to put on an EM for the boards exam because it does have such a classic appearance. But it's going to be haphazardly arranged fibrils. They are a very specific, well, they are a size that is usually 9 to 11 nanometers in cross section. So you're not the length of it. The length can be variable, but the actual structure of the material is 9 to 11 nanometers. And I want you to notice that what's happening here, it's not like I measure that full thickness. The way the bar works is my bar was so much smaller that it does the edges of the bar, it looks like this. So it's not, I was measuring, let's see if I can even make this a little bit bigger. I was measuring like this fibril right here. And the way that the annotation software does it on the computer shows it like this is the thing that you were measuring. Oh no, no, I apologize. I wasn't measuring this one. I was measuring this one. Hopefully, is my arrow showing?
Yeah.
If you think about it,
There's
like if
actually
you think
two
of a bar
lines.
graph where it has two edges and then it has the line. My line is so small, it's trapped between these two edges.
You can kind of see it a little bit better, Rachel, on those ones.
On the 11s, yeah. So the
yeah.
11s, yeah. So here, that was my bar that I'm measuring, and then this is what the program puts in for your edges. So you can actually see the difference between on the 11 measurements versus the very narrow ones. So I do measure them at the time I'm at the microscope, but hopefully everybody can start to pick up these haphazardly arranged. They are non-branching. They are mildly electron dense, and they expand the mesangium. Sometimes they will expand the capillary walls, and you will actually see them kind of haphazardly arranged within the GBM. And then sometimes they do that weird thing where they make little spike-like projections. So along the capillary wall, they might like aggregate together and nobody knows why, but they will occasionally aggregate together and how do I want to say it? Then like make these little tiny spike-like projections along the capillary loop. So this I can't tell if that might be one of those, but I think that's actually going into the mesangium again. But all of these all these little like fibrillar things are the amyloid fibrils. Some of the capillary walls look fairly normal, and our podocytes are obviously having problems because we've lost our foot processes. So there's foot process effacement as well. So the capillary loop itself looks good, but there's amyloid here in the mesangium. And again, more podocyte injuries. So all of the foot processes that should be here are absent. And then the other thing that the podocyte does when it's injured is it makes these little tendrils extending from its cytoplasmic body. And that's why all these little things here, these little little microvilli extend out from the podocyte. It's just one more signal that the podocyte is damaged. And we see it frequently. It can happen in any type of disease, but it gives you a hint that the podocytes are damaged. Any questions? So yeah, so I have never done thioflavin. I'm not sure. Oh, cool. That's cool that you did it. You were able to do it on cytology. That's neat. I didn't know you could do it on cytology.
Yeah, you just have to have enough material, and that's the problem. Most of the time, we don't get enough material that's at the actual amyloid to do it on.
Oh, okay, makes sense. Okay. So that was an interesting case because it did kind of give us a quandary as far as the the biopsy service. And Dr. Lobato, I apologize that your trainee was not here to present the case. And was there anything else? You said not much as far as that the autopsy kind of showed similar things you would think of in CKD.
Yeah, I think the only other thing on her presentation was we weren't sure if we had sent over all the gross slides to show the couple of lesions they saw there.
Oh, okay. Do you have it on the presentation there?
Let me see if she did.
She
It
did
was
send
a
me
what-
an email and I was like, oh, or I think you sent an email to me over
I
the
sent the
weekend.
email, yeah.
Yeah.
Let me see if they're there. Let me go back to share.
Well, she's
We
doing
were going to put them in at the end if, just in case. I honestly don't know if that was the comments. Oh, the reason I forgot to say, or in the discussion earlier, that the decision to go forward with extracorporeal therapy is that the hyperkalemia was non-responsive to our typical medical management scenarios. And here are some of the gross findings. You got these, Rachel, or
I
not?
think she sent them. I don't have them up on my thing. I
Okay.
do want to add them to the file so we have them in our records.
Okay, they found some bilateral ventrolateral erosions on the tongue. The lungs had marked diffuse pneumonopathy with edema, and then the kidneys were the most remarkable. This is kind of a mag view of, I think I can even magnify it further so you can appreciate all of the little brown dots there from the Lugol's. And when our pathologist first showed this to me, he said, it's definitely amyloid. My first response was, well, Rachel said it was probably some non-amyloid fibrillary.
And I honestly
And-
don't know how those would behave. Like some of the type 3, I guess the type 3 glomerulopathies where it's that weird type 3 collagen. And she was young, so it doesn't mean, I mean, like I would have had that on my differential list anyway.
Yeah,
I don't know how it would stay in with the Lugol's. It'd be interesting, but we get those cases like once every 3 years, so.
yeah, exactly. So, and then these were some of the
They're gorgeous
histopath
photos.
from the lung and the stomach and the tongue. I think these are just all kidneys that I have the photos of, but he described the lung had a severe diffuse interstitial fibronecrotizing pneumonia with severe edema, hyaline membranes, and suppurative bronchopneumonia. The stomach had submucosal mineralization and, of course, edema and a ulcerative glossitis in the tongue.
And I would say, as we're getting ready to run out of time, that this is actually very classic. Those are gorgeous. That is a gorgeous congruent. So, and see how green that material is. Honestly, I wonder, Hokiep, if maybe the lab didn't cut your slide at 8 microns.
I mean,
Because there was a lot in there.
that's a possibility because like this is what I'm used to.
Used to when we see it. So it's
Mhm.
wonder if so that might be the whole thing about, hey, if you cut it thicker, you're going to be able to catch it easier. But the stomach, if you can go back to the description of the stomach, this is classic for cats, which I think is interesting as a difference between dogs. So dogs in uremia, so this cat that was a creatinine of like what, 12 or 14. In uremia, they will have a gastritis. They'll have a true inflammation of their stomach, and they often have vasculitis within their stomach, fibrinoid vascular necrosis, and a lot of inflammation. Whereas cats mostly have like mineralization, and they don't necessarily have the true inflammation that you see in dogs. And Dr. McClelland of our group and Dr. Quimby published that a while ago. But cat uremic changes in their stomach is more of a mineralization pattern and not necessarily an inflammation pattern. So they look a little different. And then the lungs can be very different depending on how much true pneumonia there is. They can mineralize their walls and just have mineralization, or you can, both species will have, can have some degree of inflammation and uremic pneumonitis. You can have uremic effusions a lot of places, and you can have uremic encephalopathy, although that's usually a clinical standpoint decision. The clinicians will say, you know, the cat's depressed. They're obviously sick. They're very ill. We as pathologists have not noticed what a uremic encephalitis or encephalopathy, I guess would probably be the better word. We don't know what uremic encephalopathy should look like from a pathology standpoint, but clinicians do think that it does happen. And from a human background, the people that get dialysis say their head feels clearer, they feel much more aware and able to process things, and even advanced digital imaging. So I think it's a PET scan. I think they did a PET scan, does show differences in post-dialytic brains versus pre-dialytic brains. So there is something going on there from the brain standpoint, but pathology-wise, we're not really sure what it is. Okay, any questions? I'm sorry we went a couple minutes over, and we'll try next month to actually activate the quizzes for you guys, and so we can have more engagement. Okay. I hope to see a lot of you guys next week at Kidney Week or Renal Week.
Thank you.
Thanks, Rachel.
Thank you.
Rachel, if you stay on for a second, we can try to troubleshoot
Oh yeah.
the PolyV. I think it's really just that the one thing I was wondering, did you log into PolyV on the actual PowerPoint?
I thought I was. I had.
Do you, Mary and Rachel, do y'all want my help? Because otherwise, if not, I'm gonna go to the scope. The
Go to
EM
the scope.
No.
I go play at the EM scope.
So I created the images. I created the images, and then I created the questions, and then I said insert slide, and I had PowerPoint open.
Right, but then when you have your PowerPoint open, I can't remember on a Mac and a PC, it's a little different, but on one of them, and I think it's the PC, you have to actually log into
I'm on a Mac.
Oh, maybe it's on the Mac then. One of them you have to log in, like you have to actually go to the PolyEV.
I was logged into that. I logged in through the Texas A&M, like I did everything for that.
While you're in your PowerPoint. It's
it still has our Australian polls and stuff like that.
Yeah, I always have to troubleshoot or like go through it each time just to like figure it out, but it just seemed like it wasn't activating for whatever reason, and I thought maybe that could be why. Perhaps not though. You want to share your screen?
Yeah,
Open up a PowerPoint of mine to let's see, I have a lot on my teaching one here.
So start the presentation node.
All right, let's see. Record slideshow. I do.
I wonder if I could.
Yeah, you might learn it. So mine doesn't even show up until I like if I just open a PowerPoint and I'm not logged into PolyEV, then it doesn't even show up, and then I have to launch the login window, and then it works.
Well, like even when I did take the picture of my camera, it's still trying to get me to log in. And what was the thing about how we got around without logging in Australia?
Because when the poll's activated, it shouldn't require logging in to answer a poll. It should work automatically. So, yeah, so you're logged in. I don't know what the deal is. And why is it not working? It could be that something was blocked because I did see it asking Poll EV asking you for like permissions on your computer, and I don't know.
Oh, I think that was PowerPoint asking me, and I gave it permission. Well, I mean, I guess I should probably figure some of this out before next week. And
Yeah.
HealthCamp is gonna help me kind of moderate the whatever person. So I guess because even when we did Australia, we didn't have any virtual people logged in that we had to deal with virtual. We had everybody in the room, correct?
Yeah, I don't think there was virtual attendance there.
So I will need to figure that out before Thursday next week when I do the lab. So HealthCamp and I will practice. And then hopefully knowing how to do it that way, we'll have people in the room and then we'll have some virtual attendees, I think, based on that. We'll be able to.
Yeah, it's still not like active for some reason. I still have my text for your Poll EV thing and it's still not pulling it. Like it should just automatically pull up whatever question you're on. It's just not. So there's something funky going on with it not registering
I know I
that.
had to create my questions and then you actually were the one who I had like you did everything. I just created questions and shared them with you.
Yeah,
Because
but the only thing I did was insert them. So, and
was
like
that
just
because you actually have I mean, I think I was like an add-on to like I had to get permission from your TMU people to be like part of the team. And I know like Mary Thompson had that too, but like I don't think I ever did any activation. That's why I was like, I remember that Mary had to activate something. And so but anyway,
yeah,
I can
yeah.
check it and see if HoCamp has one too, right? Because she's a teacher.
Yeah. The other thing, it wasn't working on mine that I opened just now, but then I had to go back and like actually authorize it on, yeah. Yeah, that's interesting. I probably should have shared my screen. So when I first opened this, it wouldn't do anything, but it had the launch and
Oh yeah, I didn't see that
login
at all.
window. And then once I launched the login, I was able to log in, but then it still was not doing anything. It was kind of like doing a little circle of thinking thing. So I went back to the Poll EV on the website and then it said I need to authorize. And so I needed to authorize that user. So maybe that's something that like here, I went here and it said access requested. Do you want to allow Poll EV to use this device? And I had to authorize it. So I don't know if
Oh,
you did that.
I don't see your pop-up window. I only see the.
Oh, sorry. I did not share my screen. I shared that window in
Yeah.
particular.
But a pop-up did say, did you want to use it? Okay.
Yeah, so it said
Oh,
access
I never saw
requested.
that.
So that may be the hang up too,
Okay.
if you didn't see that. And that was after logging in, it just automatically popped up on the Safari.
Well, and I had tried originally because I'd done some questions with Teams last time and then we moved to Zoom. I just opened Zoom and I was trying to do it through Zoom because there is a Poll EV like add-in through Zoom. But it like Zoom didn't recognize I was TMU because it was like I kept trying to log in and it kept saying you don't have an account. And then I tried to log in with my Gmail, it said you don't have an account, whatever. It was the only way I would like allow it was trying to use and the only password I have saved for Zoom is my OSU one. So anyway, point being, I probably haven't officially created a business account for Zoom.
You
Like
might
it really
have
wouldn't let me
to-
do one. I did try to do single sign on and it just said I was not, and it even gave me like a send this to people to say you're not a user.
You could maybe fix that if you think it's a Zoom PowerPoint issue, which it very well may be. I mean, I guess you could test it on your own computer. Like if you can respond to your own poll on your computer, then it's probably a Zoom PowerPoint thing. But if you can't, you
Okay.
can't even respond to your own poll, then it's something needs to be activated on the
Okay.
poll thing.
Okay,
I
well,
bet we could get you Zoom access if we contact
but it's
IT.
weird because the way, and I can actually make Summer change it, but like Summer gave Rachel Cianciolo a Gmail administrator for the ACVNU account, but not TAMU, which maybe she just needs to make it to the TAMU one.
Maybe that could be too.
It's just, I mean, that's yeah, it's just, I kept getting so many error messages. And then I was like, I'll just create it in Poll EV directly and then try to launch it through Zoom. And okay, well, whatever we did didn't work, but HoCamp, we have like all, like, I think she gets there Tuesday night and then my lab is like Wednesday afternoon. So we'll have plenty of time to figure it out, hopefully, or figure out some kind of way to have
Hopefully.
interactions. And whatever I learn, I will bring back for April. So,
Yeah, sounds good. Well, have
okay.
fun. Have a safe trip.
Yeah, I hope nothing happens. Over there. It'll be
Nothing
fun.
happened.
I'm excited to see everybody. But you know, it's always can only stop.
Oh,
Right.
you mean leaving your pets?
No, I mean just no. I'm just being in DC, that whole area.
Oh,
It'll be
oh
fine.
yeah.
It'll be fine. It'll be fine. So
We
okay.
had a talk yesterday about the urine microbiome and actually UTIs in postmenopausal women. And the speaker was hilarious. And she there was a question about, it's interesting. We usually think about diversity in bacteria being a good thing, but you're saying in the urine, it's a bad thing. She's like, yeah, the current administration would love the urine microbiome because it lacks diversity or should lack diversity.
Oh goodness.
That's great.
Yeah, yeah. So but yes, I
Yeah.
get there Wednesday, or sorry, I get there Tuesday, like midday. I think that Hogan said she gets there that night. So
Nice.
we will practice, and if we have any questions, we'll ping you to see if you have any advice about stuff. Are you going to be able to attend virtually at all?
No, just kind of looked at it. There's really only one day for $600. There was really only one day that it made sense to attend. And so she's going to see if there's access afterwards. And if there's any particularly good lectures, I can look at them after.
Okay,
But
that's good.
yeah, it was just a lot for one day of lectures that I may or may not
Yeah.
even be able to attend all of because of other obligations here.
Yeah, I understand.
Yeah.
Okay.
Yeah. And are you going to bring your Mac to work on, or is it going to be on a PC?
I only have my Mac. My PC is my Zoetis one, so
No, I mean, like they probably have a computer there that they would have you use it on.
yeah, I
and-
haven't heard what the scenarios. I should set up with Summer to see what the scenario is. But yeah, my Mac would be where I could create everything. I mean, I'll bring both because I'm still technically working for Zoetis, so I'll have both laptops with me.
If they have
Um,
a PC that they want you to do your PowerPoint on and you transfer it over, then Poll EV is a little bit different there. I think that is the one where there's a little login to Poll EV on the actual PowerPoint.
And we did that because we basically that's why we had to put everything on Dropbox for Alan, right? And then he had his PC that he opened everything.
Yeah, he wanted everything on his PC.
Got it. Okay, that makes sense. Okay, I mean it doesn't make sense, but I do remember that now. Okay, thanks. Bye.
Bye.